All right, thank you for joining us on The Health Advocate. Like the intro says, my name is Matt Dinsmore. I'm a nurse practitioner. Over the next 4 weeks, we're going to be discussing an interesting model that's beginning to sweep the nation. Patients love it, providers love it, and now there's bipartisan legislative support that is beginning to drive this model, and we want to make our Spokane users aware of it. This first episode, we wanted to do the Direct Primary Care 101, which is the name of this model, and we thought, what better place to start than the place that it started? And that is with Dr. Garrison Bliss out of Seattle, Washington. That's right. Its birthplace was here in Washington. And we also have some newcomers to the game, if you will. Dr. James Bailey with Artisan Primary Care, and Dr. Drosten Baker with Baker Direct Primary Care. We need to simplify our names, I think. So that's a long enough introduction. And if anybody can answer this question, Dr. Bliss, it's you. And what is direct primary care?
Well, I mean, there's a lot of ways to talk about it. The easiest thing to say is that it's one of the simplest ways you could possibly set up a relationship with a doctor and a patient. The patient pays their primary care doctor a monthly fee. The doctor provides a service, which is access to 24/7, 365 healthcare at the primary care level for a fixed monthly, quarterly, semi-annually, or annual price. And it involves no interface with insurance, and it involves no interface with the complexities of modern day medicine, which is most of it built on the idea that for some reason, insurance needs to be someplace in the middle of this relationship. It was constructed for a pretty obvious reason, which was that the way the healthcare was going back in the late 90s, it appeared that primary care was on its way to destruction. And it's continued to devolve just because of inadequate support, mainly from insurance companies. So we decided instead to start doing a deal with our patients, and which turns out to be a pretty good way to do that. So that's the basics of direct primary care. We have a contract with our patient that tells them what they can expect. They pay us a monthly fee, and we're off to the races.
So to save primary care a couple decades ago, you kind of mentioned where and why it came from to help save direct primary care, and this foreign model that is alien, almost, if you wish. We know where it came from, why it come from. The question is, did it come in peace? What's your answer?
Did what come in?
This model, is it
direct primary care?
Peace? Yeah.
Yeah. Well, no. It has been a very difficult thing to get the people who currently run the healthcare system to understand what we're doing, because for some reason we have come to believe that healthcare is insurance and that insurance is healthcare. And nobody really remembers back in the 1960s when we invented Medicare and Medicaid, which is the first two really big government models of insurance for health. For that, insurance was and most healthcare was by having doctors and patients work out the deal. What's this worth, and how much can you afford? And you can pay me in dollars. You can pay me in chickens.
Right.
And whatever it is, we can do the deal. It's a basic marketplace idea for healthcare.
Right.
But insurance was not fair, but to improve the likelihood of survival of hospitals, which were expensive things that could not be afforded by many, many people. So insurance began to be utilized in the 1900s. But it was in 1964 that Medicare and Medicaid were born, because the federal government was incapable of producing a healthcare system in the United States, mostly for political reasons. And that has evolved, and part of that evolution was a decision about how to price things. And they decided that primary care was worth a lot less than specialty care was worth, which was worth, in turn, a lot less than hospital care was worth. And eventually, primary care was largely priced out of the market. So this was a response to that.
Yeah, it sounds like it's.
We decided why don't.
Yeah, go ahead.
Go ahead. Yeah, it became clear to me actually in the early 1990s that my own primary care practice in Seattle, it was called Seattle Medical Associates, that was going to actually go into the red within a few years because our costs were going up and our income was not, because the insurance companies were not paying us enough to make that happen. And that's when made the move to a monthly fee medical practice, because that looked like the simplest solution to that problem. The thing about direct primary care, the way that was created, there were all other kinds of things that were done in that time. There was fee for service, direct dealings with doctors and patients. The reason I got into this was because I had decided long before that healthcare itself was beginning to go down a kind of a bizarre track. That because we were working for insurance companies, we had begun to our idea, the forces that were driving good care, which had to do with our responsibility to our patients, were being altered by the financial reality that the only way you got paid was to do what the insurance company wanted you to do. And the manipulation of insurance companies and funding became and continues to be the number one enterprise of healthcare in the United States. And it turned out primary care wasn't very good at manipulating anything. We just wanted to take care of people, and we didn't have the cash flow necessary to produce highly sophisticated ways of billing insurance.
Right.
So we ended up on the short end of the stick pretty much all the time. So my decision was to see if my patients would do a deal with me to produce a stable, high-functioning care. To decide how to do that, I decided to take a few months and look at the question of what ideal primary care might look like, because I didn't really want to replicate mediocrity. I actually wanted to do something that would be able to perform better health care at a lower price, which I assumed was doable. And I modeled out. I looked at the question of how many people I thought I could or should see a day. I looked at the question of how often I should see people for an annual or intensive exam. How much time I wanted to have set aside in my practice every day so that I could see urgent care, so that people who were sick didn't have to wait.
Right.
And having modeled that out, it became clear what I thought would be an ideal practice model in terms of the numbers of patients that would be in the panel. And at that time, I thought it was something between 600 and 800 patients. I now think it's probably closer to 400 patients, but that's because I'm older and my patients are older. But I think for young people, 600 to 800 patients isn't a bad deal. And then since I understood the costs of my practice and I knew what kind of salary I needed to make so that my kids could go to college, I decided to take our annual costs, including my salary and my staff and our rent, which is pretty much all the cost of primary care, and divide it by the number of patients. And it turned out we could do that for about $50 per member per month.
Wow.
And so our first practice that we did was between $30 and $60 per member per month in Seattle, and it actually worked, which kind of shocked me. I was prepared to quit medicine and learn programming.
Yeah.
And I'm glad I didn't.
Well, thank you for taking the risk. And it's interesting because it's such a simple model that you're describing, but it's such a mental shift from what we are used to or what we expect health insurance to cover. Dr. Drosten Baker is off to my left. He's going to be starting a direct primary care practice in Liberty Lake, Washington this fall. And currently you're part of a large corporation, right? You're going to be leaving that to open up your own direct primary care practice. You're leaving money, you're leaving benefits and security and support. And as I continue to go on, this sounds like a crazy decision, and I'm not sure I understand why you're doing it. So what is your motivation? Why are you leaving the comfort and luxury of a big corporate to open up your own direct primary care practice?
became aware of direct primary care. So I've been practicing for about 10 years now, including residency. And it became clear to me, 3 to 5 years into my practice that something wasn't right. And I kind of broke it down into like 4 different areas that I found and felt like something didn't feel right about how medicine was being practiced. The first thing I noticed was just increasing, pressure on doctors, to do things that were non-clinical, things that I wasn't trained, to help people with. So that was taking up, an excessive amount of time.
The billing, the documenting.
The billing, the documenting, all the extra paperwork, documenting a note to satisfy an insurance company to prove what I was doing was correct, and so I could get paid. The second was just, having then the insurance companies turn around and push back against me on things that I was trained, scientifically, medically proven to be beneficial to patients, and then they turn around and deny things that, we're trained to do, images, medical tests, referrals, that type of stuff. So that seemed, very, the denials kept increasing. Why is this happening? Why is this way? Over 5 years of taking call in a large medical, multi-specialty group, I rarely answered calls from my patients. I can count on my hand, 2 hands, how many patients of my own patients that I took calls from. I found it difficult as I interacted with people in the community. They couldn't get in to see me when they wanted to see me. I was doing wellness visits that were mandated by insurance companies, but yet I couldn't see my own patients to take care of them and give them the care that they needed. So, after all of this, kind of looking at these different things, it kind of became obvious to me that insurance companies were aligning themselves more with, big employer groups, hospitals, to take care of their patients, but really was, setting patients up, for failure in my perspective, because they couldn't get the care they needed when they needed it, and in a way that you could build a relationship of trust and care for the patient. So it kind of came to the conclusion that systems were, set up to process patients rather than to really truly care for patients. And, that's the direction we seem to be going in medicine is going for big systems, working with big insurance companies that take away the patient-doctor relationship. Which I hope to restore in direct primary care, and talking with people across the country and seeing what you guys are doing and what Dr. Bliss has done, it's doable, and I'm excited about it to really kind of get back to the roots of medicine.
I mean, everything you say is very patient-centered, very patient-focused, and I know for a lot of providers that this model is kind of crushing them and their whole purpose for going into medicine. You look at some of the statistics, 1 physician per day commits suicide, and this rate is higher than in any other profession. Male physicians are 70% more likely than the average population to commit suicide. Female physicians are 250% more likely to commit suicide. For every 1 hour of patient care, there's 2 hours of documentation now.
Absolutely.
The average appointment lengths are somewhere around 8 to 15 minutes per patient, and providers are seeing well over 20 to 25 patients per day. 20 patients is a slow day in family medicine, which is kind of crazy. And many people are claiming, or you see, okay, we're seeing provider burnout. This is evidence of provider burnout. And it's hard to call it provider burnout when you're talking about people who gave up their 20s and plenty of overtime, becoming medical doctors, and there's no burnout there, but now they're burning out and they're committing suicide, and so burnout maybe not be the right choice. And there's kind of this new word that's being thrown out called moral injury, and you're taking physicians who truly want to help people,
Right.
Then you put them in the system where they can't do that, and they're feeling like their purpose has been crushed, and it's leading to some of the things that we're seeing now. Dr. Bailey, what has been your experience? You've been in Artisan primary care for almost a year now, doing direct primary care. And what's been your experience doing direct primary care versus, in regards to your job satisfaction, versus the typical insurance billing model that you're familiar with?
It's night and day. And I think I completely agree with what you're saying, that to take a group of people who have proven to be extremely resilient and in pursuit of a calling, because I think medicine is more than just a job.
Sure.
I mean, there's much easier ways you could make a lot of money.
Sure.
You go into medicine because you actually want to take care of patients. And then after all that, multiple tens of thousands of hours of training and hundreds of thousands of dollars of debt and decades of training,
Sure.
to then on the other end not actually get to do it.
Mm-hmm.
I mean, I don't care how good of a doctor you are, you can't fix all somebody's problems in 8 minutes.
Right.
And if they can't get in to see you, you can't help them.
Right.
And so I started my practice right out of residency, which, if anyone's not familiar with residency, basically it's like an apprenticeship. The last year of residency, you're functioning like a doctor in the normal insurance world. Yeah. So I got that taste of it, and that was enough for me to know that I can't do this. I was leaving every patient encounter feeling like I had let them down in some way because there wasn't time to get to what they really wanted to get to. Mm-hmm. Or the patient, I knew what needed to be done, but we knew insurance was going to make us jump through a bunch of hoops, things like that. And now I spend all my day being a doctor, which is what I always wanted to be.
Sure.
And so I'm in a room with a patient. We're the only two people there.
Right.
I mean, no figurative insurance companies in the room tell us what to do.
Yeah.
And I can just do what's best for them.
Yeah.
And it's not that it's easy. It's a lot of work still. Mm-hmm. It's a hard job.
Sure.
But it's a great job.
Right.
And it's not what I got from the insurance world.
Okay. So, I thank you for submitting your CV and resume. And as I've been reviewing that, what I realized quickly is that you've probably earned more in academic tuition scholarships than I have in the past 5 years working as a nurse practitioner. You've had plenty of scholarships.
Certainly earned more in scholarships than I have in real money.
So it turns out you're a smart guy, right? And I'm sorry, Vinny, my producer, it's Vinny, not me. He's saying that doesn't mean you're business smart, right? Okay.
Absolutely.
Talk to Vinny. I don't know, Vinny. That's rude. Okay, smart guy. Explain to me financially. Okay, we know the quality of life is there, but financially, how does this model work? Mm-hmm. How can this work? Why aren't insurance companies doing this and providing this high quality care? How can you do this in direct primary care and be financially afloat?
It seems kind of magic at first, right? To be like, I'm going to give you an affordable monthly rate, and then everything's taken care of.
Yeah.
The thing is that, and Vinny's right, I'm not good at business, and that's something that's great about direct primary care, is it is a pretty simple model. Mm-hmm. Once you get over the fact that it's different, it's not complicated.
Yeah.
I mean, we pay memberships for gyms and cell phones and whatever, and this is on the same order as those things. Mm-hmm. So it's not complicated. And the reason it works is because medicine in the insurance world is so bloated and inefficient that, at least in primary care, it's really hard to actually generate money. Specialists are different because they can bill much higher.
Sure.
But just to see the 24 patients a day, you're going to need multiple schedulers and a big waiting room for them to hang out. For all those notes that you write, those go to insurance coders, who is a person you employ, and it's a certificate position. It's a high-level job. Most practices have more than one of them.
Yeah.
You need a bunch of MAs or nurses or other clinical staff to handle the incoming calls from all these patients. There's so much overhead.
And you're doing all that, is what you're saying?
I don't have any employees right now
just
in my practice. It's just me.
So who checks the patient in?
Me.
Who's taking their blood?
Me.
Who's answering the phone call?
Yep, it's all me. Yep.
Okay.
And I pick up the phone, I schedule the appointments, I bring them back, take their vitals, do it all. Mm-hmm. I don't have to pay all those other people. Not that all the other people are useless. There's excellent, wonderful clinical staff.
Yes.
But things like having a position for a coder that exists only so that this system we created we can then implement, that's a wasted resource.
And the beauty of that is you then have access to your doctor. Mm-hmm. It's very simple, and it's great. Patients can talk to their doctor when they need to talk to their doctor to get the advice that they need. To be able to help navigate the system, lower their costs by getting in to the primary care doctors, where we can lower the cost of their care. Right. It's huge. Mm-hmm. It's exciting to know that there are people like Dr. Bliss out there that have pioneered this, and it's happening across the country. I've watched it for 4 years. Yeah. People are doing well with it. They're bringing about change that we need to see in this country, and that's, eliminating insurance from primary care and really restoring the patient-doctor relationship, letting insurance become what it should be, and that's to take care of major medical issues. Sure. And let us in primary care, let Dr. Bailey and I really help you navigate the costs of care, help you lower your costs by transparently working and knowing. I tell people all the time, it's like going to the grocery store. Yeah. You're not going to go to the grocery store and buy a ketchup that's that doesn't have a price below it. You're going to sit and compare the two, and you're going to figure out which one you think works best for you. And that's the same thing in primary care. We're going to lower costs. We're going to make our care transparent and our pricing transparent to labs, imaging. You'll know all that information as you're doing it. Very much like you would use your auto insurance. We don't use our auto insurance when we go in to change tires and rotate our tires and change our oil. The body's going to break down, and we can provide efficient, affordable, accessible care to help you navigate those challenges you face in a cash environment and let your insurance work for what it should be.
Absolutely. Yeah. Well, okay, so pie in the sky. This all sounds really great. And Dr. Bliss, I'm going to have you kind of answer this question. But truth be told, there's a looming, it's already present, but further looming physician shortage, right? And we know that you guys are kind of you're a unique breed. You have family medicine doctor that's graduating and going into family medicine. What, 10% or less of MDs are doing that now? And so okay, Dr. Bliss, this is for you. How do we justify this model of direct primary care and say, okay, now we're going to take a physician out of the traditional insurance billing world. We're going to give them a panel that is 1/4 the size of what they would be dealing with in the insurance system. How are we not making the physician shortage worse?
Well, this is a question that always comes up. When we first started out, the ethicists were always talking from the wings about how we were going to destroy healthcare, and we were going to help a few wealthy people, and that was going to be it. The real question to ask is not what are we going to do to the healthcare system. The question is, how did we ever create a system that was this bad in the first place, and why does everybody want to cling to it, right? So we've created a gigantic middleman that gets 15% of the cash flow of all healthcare in the United States that doesn't go into healthcare and into taking care of people. In fact, it gets in the way of taking care of people. We were spending like 40% of our income in our office just getting paid, and we had to have a bookkeeper. We had to have people who just worked on companies. We had to buy software and hardware, and we had to submit the billing in the form they wanted to submit it. And when in primary care, you see, if you're a cardiac surgeon, you can hire those people because you're going to get a lot of cash back. And when that happens, you can afford them. But in primary care, we can't afford that. So it was actually cutting into our bottom line in a big way. And we were getting paid 1/3 of what everybody else was getting paid to begin with. Right. So it was killing primary care. So if you want to resuscitate it, maybe we should stop doing the thing that was killing it. So if you want to grow more primary care doctors, there's some things you might want to do. The first of the thing is to make it possible for them to do their job, to make it actually plausible that they can take care of people in a real and effective way. And there's data out there now that when you give doctors and patients enough time, and you allow them to interact with each other, the amount of utilization of the rest of the healthcare system drops like a rock. By which I mean 20 to 30% reductions in the cost of healthcare overall, because the people who are getting 5% of the pie are saving you. So what if primary care doctors actually could have fun doing their work, could see a reasonable number of patients during the day, and could actually fix the healthcare problems of the United States by just not utilizing the ERs, the hospitals, the CT scanners, the MRI scanners, the unnecessary laboratory work, et cetera, et cetera, et cetera, as much as everybody else is. And it's not that we haven't been looking at this problem for a few years now. We have a number of scaled organizations doing direct primary care who have very similar kinds of data. The only problem is that there are many oxes to gore when this happens. So who's making money in the healthcare system? Ask that question, and then you will know who's opposed to this idea. So insurance companies, why don't they use us? Well, there's a reason they don't use us, because they don't want the cash flow to drop in their system. They're supposed to work on keeping the costs down, and all they really have to do is convince the insurance commissioner of each state that they tried and it didn't work. And they can make more money every year because they get 15% of whatever their premiums are. So as long as premiums are going up, they're making more money. So we're not going to have their cooperation in this effort. The hospitals, likewise, they love the idea for their own employees to have direct primary care doctors working for them because it can save them a lot of money. But then they look at the question, what if everybody did this? What would we be doing in cardiac surgery? What would we be doing in our CAT scanners and our MRI scanners and all our centers of income?
Sure.
So there's a lot of resistance to what we're doing.
I think the people that are, why this can be successful is because generally when you put providers in control and within their communities as primary care physicians or even specialists, they are motivated to help people. I'm convinced that providers would be willing to maybe not drive the Maserati that they're used to if they still can take high quality care of people. And so that's why I think hospitals will eventually kind of go this way, because we're truly helping people and help save them costs down the road. As I wrap up, Dr. Bliss, I'm going to speak for you, but I'm going to give you an opportunity to kind of share the best way that our listeners can follow up with you. If you want to check out Dr. Garrison Bliss, it's blissmd.com. He's also kind of the pioneer and front leader of the Direct Primary Care Coalition. You can Google that and see they'll be flying into Washington, D.C. here in September. You can kind of keep up to date on their newsletter. Go ahead, Dr. Baker. What's the best way for listeners to contact you?
BakerDPC.com. DPC is Direct Primary Care, so it's pretty simple. You can also email me at info@bakerdpc.com.
Okay, great.
Yeah, and I also have a website. It's just jamesbaileymd.com. Bailey, B-A-I-L-E-Y, just like the Irish cream. Check it out on the website. Easy way to contact me. Everything else, email, phone numbers, all on there.
Awesome. Well, thank you to our guests for attending today. A very lively discussion. Your mothers would be proud. You too, Dr. Bliss. And if please tune in next week when we will get a patient's perspective, actually a panel of patients' perspective on direct primary care and how it's impacted them and why did they make the leap to join direct primary care. For now, my name is Matt Dinsmore with Healthcare Advocate, signing out.
Ask the host a question, recommend a guest, or hear this program again on Facebook, YouTube, Twitter, Apple Podcasts, Spotify, or SpokaneTalksMedia.com.